Welcome to the session for today. It's a blessing to have you with us today. I would just like to remind everyone to make sure that your phone is on silence and that we use the chat box to introduce ourselves. You have to state your position and those that you are joining with on today's session. I think we'll see other participants joining us, but we will continue with the session for today. It's a pleasure to be here. Before I proceed, I would just like to ask my team members to introduce themselves as well. Starting with Mr. Kelly next to me. Thank you.
Afternoon, colleagues. My name is Sabeto. Okay. Next from teaching native candidates. They are taking you for a presentation. Thank you.
Good day to everyone. My name is Hospice, and I'm here at Hospice at home. Pleasure to have you in today's session. Thank you.
Hi, my name is Setabile Mzimbi, and I'm here for the social work department.
Thank you so much, team. I would also like to ask our participants to introduce themselves, starting with Temalangen.
Hi, I'm Temalangen Dlamini, a nurse in Babane Government Palliative Care Unit.
Thank you. Fortunate.
Hello, I'm Dr. Fortunate Makakula from the University of Eswatini. I'm a lecturer in the Midwifery Science Department.
Thank you so much, Doctor.
Thank you.
Thank you. Thank you so much. Well, just a recap on our last session. Our last session was about the ongoing goals of care discussions. Where I picked, which was, okay, the case presentation. The case was presented by Mercy here at Hospice at Home. And what I picked the most was that communication is very key in palliative care. And that is good to involve the client with her or his care. And that the goals of care of the client may change from time to time. So it's good that you have to recheck whether you're still in the same line with what the client wants for her care or his care. And we also had a presentation from Manzini Government Hospital in Moneni, where we had a case presentation. It was a follow-up case of a 43-year-old female diagnosed with cervical cancer. The client was diagnosed in 2019, stage 1, but currently the cancer is at an advanced stage. He did chemotherapy back then in 2021. I think he did about 6 cycles of chemotherapy. He also did radiation. The main concern from the client was that, okay, he complained of pain. The client also had, I think, a conflict with her father at home, such that she didn't want to go back to her parental home after being discharged at the hospital. He wanted to stay with her aunt, or rather die in hospital. So it was just a major conflict. So one of the plan of care was to conduct a family meeting so that they would discuss how to help the clients with the issues he had with his father mainly and his family members as well. And also that the client there may be a follow-up case so that they can check on records of care while at home. So it was part of the plan that they will follow up the patients even if she was at home. And also to manage the pain. We know that one of the main goals of palliative care is to pain management. So making sure that the client is as comfortable as possible. So those are one of the things that were discussed on the last session. And today's session, we will talk about the court status discussion. We'll have a case which will be presented by Mr. Sabelo Kele. We'll later then have a case from Mabane government, from the palliative care units. So at this point in time, I would like to ask Mr. Kele to proceed and to share the case with us. Thank you, colleagues.
Good afternoon, colleagues. Once again, is Mr. just said, from Hospice at Home and the leadership of Hospice at Home, Eswatini. I will be taking you through today's presentation. Today's session is about discussion of life-sustaining treatment. That is called status discussion. This is where we include just quite a number of parties here for the decision making. It's more like a family meeting. There are parties here involved for an effective discussion, called status discussion. So in our outline, we will be defining what called status discussion is. Then when to consider called status discussion, then we look at the importance of the called status discussion. Then there are things to consider during those discussions. We'll look at them shortly, and the roles of a healthcare worker during the called status discussion. So then how to conduct this called status discussion or this meeting. We'll be looking at step by step, then the conclusion. I suppose, and I think at the end of this session, or at the end of this discussion, we'll be able to know on what is called status discussion mean. So in our introduction, we can say that the called status discussion focuses on the type of emergent treatment a person would or would not receive during a life-threatening or life-limiting event to sustain life. So basically, here, there are three parties involved. So the other one depends on the other, which is the patient, which is a very important or principal party here. With the family, also is our stakeholder here, and the healthcare worker, the clinicians, can be a doctor, can be a social worker, can be a nurse, can be a healthcare worker. So the life-sustaining emergent treatment here includes the CPR or the cardiopulmonary resuscitation, the intubation and mechanical ventilation. So there are other life-sustaining treatment, although not considered emergent care. That includes the dialysis for kidney failure, the tube feeding, artificial hydration. So we can say that the patient here is centered here. It is a cornerstone of a patient-centered medicine and part of what is considered high quality care. So there are levels of cord status. There is full resuscitation. There is DNAR, which is do not attempt resuscitation. The full resuscitation here is all about the resuscitative and aggressive preventive treatment that are provided at all costs. So there is a do not attempt resuscitation or do not resuscitate. And the last one is the comfort measures only, whereby the patient would say to the healthcare worker, look, do whatever is possible to just to make it comfortable, or to cure, or to maintain, or to just to keep in comfort. Then there is a use also is a use or continuation or discontinuation of life-sustaining measures are all necessary to these discussions. So the patients have the right to choose treatment. Remember, we consider the patient, we consider the patient's rights. We do not impose anything as healthcare workers to the patient's treatment. So the patient has the right to choose treatment options they prefer without discrimination. So when looking about when to consider this cord status discussions, there are places or there are scenarios where we consider cord status discussion. We do it on admission. It can be an ICU, intensive care unit. It can be any ward. Once the patient is diagnosed with life-threatening, we consider cord status discussion then. Then on patient request, some of the scenarios say we say that the patient can request those kind of a service. So we consider that cord status discussion there. We do that meeting there with the family, of course. Then on diagnosis of a life-limiting illness, so we consider cord status discussion there. Then on goal of care discussions, we also consider cord status discussions. Then on decrease on treatment option, whereby there is a decrease because the treatment options say they sometimes they come to an end. So we as healthcare workers, we intensify these core status discussions. It should be integrated into the daily routine care. So when looking at the importance of these discussions, it is very important to healthcare service. One of which is it promotes patients' quality of life. It improves patients' care. It improves healthcare workers' competency and comfort level. So it eliminates guilt to all clinicians. So if these discussions are done, the level of competence and comfort are well observed, then there is a decrease of moral distress of healthcare worker at end of life care. So the moral distress that is gradually decreasing if these cord of status are being put on the table. So the other one is it improves decision making during a crisis. So it promotes that once these discussions are being conducted, once all these parties are being involved, so the decision-making process here becomes very easy and it improves while we do that. Then lastly, it promotes high perceived family satisfaction and less stress and anxiety for family members. We remember earlier on we touched on the family as part of this discussion, part of a very important stakeholder here, the family. So it promotes highly perceived family satisfaction. So there are many questions that the family may ask. So if we discuss that, if we give that full information to the family, full information to the patient, so the decision-making process here becomes very easy for both parties. So there are things to consider here during those kind of discussions. The goals of care and patients' wishes. So there are, in the case of disease trajectory and functionality status, when this is gradually decreasing, we have to consider those things while we there is an ongoing discussion, which is called status discussion. So ethical and legal issues here needs to be considered here also. What are the values of the client, wishes of the client? What about the legal issues? Because there are legal and ethical issues that need to be involved as healthcare workers. And I know that healthcare workers are well informed and are well aware of that kind of ethical issues and legal issues. Then the family here and the clinical team involvement. Also, the clinical team here is a very important part here in this kind of discussions. The family and clinical team has to be involved because we said on that it is patient-centered. Even though it's patient-centered, all the family and the clinical team needs to be involved for a better or for an effective conversation discussion. And lastly, the patient's spirituality and cultural values. We have to consider also the cultural values of the patient, the spirituality, what the patient believes on. How about the cultures? There are some cultural values whereby the patient cannot be comfortable of some of the procedures that are being conducted at the clinical setting. So we have to consider those. We have to consider spirituality and cultural values as well. So there are roles though of healthcare workers during those discussions. We remember that we do not impose everything. If our feelings, our values, we do not impose those, but there are roles that the healthcare worker need to have during discussions, called status discussions. So roles like explaining the benefits and the risk of such treatment to the patient and the families. Before letting the patient or the family decide, before decision making, we have to explain everything. We have to give full information to those parties for effective decision making. So in incorporating clinical ethics in decision making about life-sustaining treatment is the role of the healthcare worker during those discussions. So we provide information, I've said that earlier on, and guidance to the families. We do not judge, we do not tell the patient to do what to do. We do not tell the family what to do, but we provide information so that the family and the patient will have the full understanding so that decision making can be effective there. Then in challenging decision-making process, so we provide this kind of information to those people, to the family and to the client. Then we have to clarify the clarification there of course standards that need to be presented. Then assess the patient's knowledge and decision-making capacity. Some patients need to be capacitated and need to be informed, well informed about the procedures that are being carried out in the clinical setting. So we have to assess the patient knowledge. How well does the patient know this kind of procedure? How well does the patient feels about it? So decision making here can be very effective. Then the compensate in providing life-sustaining treatment among a variety of patients. So the healthcare worker here needs to be competent in providing those treatment and have competent and confident enough to provide those kinds of services to the patient. So we maintain good communication between the patient, family, and clinical team, because this is a very delicate matter. It includes this is between life and death of the patient. So good communication there needs to be presented, needs to be done between those three parties: the patient, the family, and the clinical team. So we know as healthcare workers that the work that is not documented is considered undone. So if you haven't documented anything, so your work here is as good as zero. So we complete documentation, and we need to have proper and complete documentation there for everyone to really understand, for the continuity of care to be carried out, because without the documentation, we cannot continue helping clients and the family. So in the step-by-step, now how to conduct court status discussion. We remember when we talked about, when we introduced this communication, that there are things to consider here. We do it in a certain way. The process here is similar to the other patient and family meetings. When I introduced this session, I mentioned that these kind of discussions are like the family meetings. So we gather all these three parties so that we come up with a solid decision making. The recommended steps here include establishing an appropriate setting for the patient, our patient, and the family. The suitable setting so that everybody can be comfortable. Then we inquiring of the patient and family, what they understand about the patient's condition. So before helping the patient here, before helping the family as well, we need to inquire the level of awareness here, the level of knowledge. How well or how best does the family, or how best does the patient understand the condition? Before explaining, before giving information, before helping, before conducting those discussions, we need to first assess the level of understanding of the patient's condition, and maybe the family or the patient. We find out what the patient expects for the future regarding this condition, we have to find out what he expects, what the family expects before we move on to something else. Then we discussing court status within the context of the patient's condition. And it's very, 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 very important. For an informed decision making, we have to have that in mind. So eliciting the patient's understanding of present condition and thoughts of the future, including the context in which the court status will be considered. We remember that we do these things on admission, so the patient here needs to give a consent, informed consent about all these things before consenting to the procedures, to the services that are being conducted in the clinical setting. We have to give information, complete information for an effective decision making. Then we respond to the concerns and emotions. That comes with competence of a healthcare worker and so for us to respond, we need to be confident of what we are doing. We need to be competent of what we are doing in order to respond to the concerns and emotions of the patients and the family. Then, with all that's done, then we develop a plan and document it precisely. We remember that we give a complete documentation. After developing a plan with the patient and the family, then we come up with the full and complete plan so that all these services will be conducted without fail. So all these things, this plan and documentation need to be precisely. So with all that said, the conclusion, they do not attempt resuscitation does not imply that the healthcare team will do nothing in the event of the patient's change in status or will receive substandard care. Full code does not imply that the medical team will continue interventions on the patients if they deem and not of the benefit. If we see that this service, this kind of service we are providing is not beneficial, will not benefit, we are not obliged to continue with interventions. With that, I'm not saying that we should not consider the patient's feelings and issues. So decreased desire for fluids and the food is a normal experience, especially in life-limiting conditions, when the patient's body is no longer functioning normal and the body shutting down from chronic illnesses. So if the desire for fluids are decreasing, if the desire for food is decreasing, we have to bear in mind as a chemical that it's a normal experience for a life-limiting condition or in chronic illnesses. So life-sustaining treatment comes with a risk. So the interventions must be measured against their effect on the quality of life. Communication and documentation, documentation of the plan of care is important for continuity of care. So if we are not communicating, if we are not documenting, the whole process is null and void. So it is of prominent importance that everything that we are doing, everything that we are discussing, everything to come up with an effective court status discussion, communication there is the key. And what is communicated needs to be documented in the plan of care of the patient. Remember that this is the cornerstone of patient-centered medicine. So the patient here is a very important stakeholder in this kind of discussions. The family as well is also important, together with the clinicians, the healthcare workers. We need to together to come up with an effective decision making. So the court status discussion here will be very, very successful. I think this is the last, that was my last part of my intervention today. I will accept the questions and comments if there are any from thank you very much.
Thank you, Mr. Sabelo Kele, for the informative presentation. We have picked up a lot from this presentation, and I hope as healthcare workers, this will help us improve going forward. It's actually a reminder of some of the things that we already know. I would just like to also welcome those who have just joined us as we're discussing about the court's status. So my pick from Mr. Kele's presentation was that it is very important to always involve the patient, the family members on emergency treatment such as CPR and intubation, and also that we should consider the right of the patient all the time. The patient's consider the patient's rights, what he says about the choices of the patient about his or her treatment should always stick to that treatment. And also we need to consider the court status discussion on admission, on diagnosis, or when the patient has requested. And also that it is important because it helps to improve the quality of life, and also, which is one of the aspects of palliative care. And also that is important because it helps improve the patient care. And it decreases the moral distress for both the healthcare worker and the patient as well. And also it helps to improve the decision making also for the patients. The other things we need to consider the cultural and spiritual values of the patient. Shouldn't impose our own belief. We just have to consider what he believes in as well. A part of the roles of the healthcare worker on this discussion is to explain everything, both the benefits and the risk of treatment, and also that the healthcare worker should make sure that he assess the knowledge and understanding of the patient, what he believes and what he understands about the treatments or what has been explained. As I've said earlier, that the healthcare worker, one of the roles is to explain everything, both the benefits and the risk. So it's good to check whether the patient has understood you very well. And also that it's always advisable, and it's something that is very key, that we document everything and we document completely. As Mr. Kele said, it's just something that healthcare workers know, that anything that is not documented is considered undone. Also, when discussing the code of status, it is it is good to consider or to establish an environment that will be suitable for all the parties involved. That is the family, that is the patient, and as well as the healthcare worker. So the environment should be off so that everyone can express anything you want to say in a good way, not feeling the pressure or anything. And also that we should assess the knowledge, as said earlier, of the patient and the family members on the illness or condition of the patient. What does the patient know about the illness? Should assess that. And then lastly, to develop a plan and to document everything that has been said on that meeting. As Mr. Kelly said, it's more similar to family meetings, just that the discussion is on kind of status here. Otherwise, thank you so much, Mr. Kelly. We really appreciate your presentation. At this point in time, I would like to give the floor the chance to ask questions or add those comments or any recommendation. This is your platform. You can use the chat box to ask those questions or to comment, as well as raising up your hand if you have something to say, so that everyone can be on board. Okay, I see a hand from please go ahead, Doctor. Thank you.
Thank you very much. Thank you for the presentation. It is my first time to be here, and you will pardon me if what I'm going to ask has been asked before. Thank you for such an insightful presentation. I've got two questions on the code status discussion. My number one question is, what if who has the final say in the code status discussion between the family and the patient? What if the patient says, I am tired, I don't want anything now, and yet the family feels like this is the best for the patient, it has to be done, and the patient says, I don't want it anymore. That is my number one question. So who has the final say? Who makes the final decision there? My number two question would be, what if in a case where the
dog.
Doctor? I think we have lost Doctor. I was still asking a question. We already got one question. He said she had two questions. So the one we had this, who has the final say on the decision making? Is it the patient or the family members?
Dr. Fortunate.
I don't know whether it's the network or that is failing us.
Do you hear us, guys?
Doctor?
Do you get us?
Can you hear us? Colleagues. It seems like we have lost everyone.
We can hear you guys, but there is some echo at times.
Okay, noted.
How is it now?
How is the echo now?
It's okay, but when Mr. Makakula was presenting, it's like it's in his position, because when everyone was talking, we could hear him clear, but when that position he's in, there's some echoing that happens.
Okay. Thank you for that. We only got one question from Dr. Makakula. That who has the final say on the decision making, whether the patient, or is it the patient or the family? I will let Mr. Kelly to answer that one.
Okay, thank you very much. This is a very important question here. I mentioned in my introduction whereabout this kind of discussions there is a patient-centered. It's a cornerstone of the patient-centered. So I mentioned 3 parties there. I mentioned the patient, I mentioned the family, I mentioned the healthcare workers or the clinicians as well. So the question here is, who has the final say in those kind of discussions? So in our ethics, I also mentioned that in our ethics, we also have to consider the rights of the patient. We remember that the patient has got rights. The patient has got the right to medication, the right to a healthcare system. So yeah, at the end of the day, we have to consider the feelings and the wishes of the patient. When the patient here is cautious, there are cases, there are scenarios whereby a patient here is unconscious. That is where we include the family, particularly the proxy decision maker in the case of an unconscious patient. So if the patient is not well aware, if the patient is cautious, the patient has the right to a medication, has the right to the services that we are providing to that kind of patient. So if the patient does not feel he can continue with the kind of the services we are providing, then we terminate those kind of services. So the patient here has a say, is the patient-centered, is a very important stakeholder here. When the patient does not feel like he can continue with this kind of services, then we respect this kind of a decision. There is a case whereby the patient here is unconscious. That is where we include the family, the proxy decision maker. There is a person in the family who is the proxy decision maker that will come up with a final decision of what to do with the patient. Thank you. And my team here will add if there is something they want to wish to add on my response.
Thank you very much, Mr. Kele, for the response. I'm not sure whether Dr. Makakula had the response, but I hope we'll write something on the chat box so that she can also get the response very well. If ever you have a question, please make sure that you write on the chat box. In the interest of time, I would like us to proceed. But before that, I would also like to welcome everyone who has just joined us. Thank you so much. We really appreciate colleagues. In this point in time, we'll have a case presentation from Mbabane Government Palliative Care Unit. Over to you, Mbabane.
Good day, colleagues. My name is Temalangen Dlamini from Babane Government Hospital, Palliative Care. I'm a nurse by profession. This is a case that was done on the 3rd of August, 2022, which was a follow-up on the patient. The diagnosis of the patient is a follow-up, and the age is a 71-year-old with the diagnosis, deep vein thrombosis, which is DVT, RED, hypertension, and diabetes. The main problem or concern we have about this patient is severe pain on left leg, abdominal pain and cramping. The patient reports that the morphine assists on the pains, but made patient drowsy. The caregiver, who is head daughter in this case, requests we decrease dose to 5 milligrams per day instead of 4 hourly. Intervention already tried by caregiver and shown to be effective. Patient is having less pain, which is with the pain score of about 3/10. So we advise to continue the intervention. The holistic assessment, the chief complaint of the patient has abdominal pains and cramping since 10 days ago, sleep on supine position to avoid being touched on the left leg. No complaints since commencement of morphine syrup at 5 milligrams, which was initially 4 hourly, and then now it is BD. And then we go to the significant medical history. Patient was tested RVD positive 2010 and commenced on ART. Later developed hypertension and diabetes and on chronic medication of all this treatment that we are talking about, of this condition that we are talking about. 10 days ago, there was left leg swelling that was noted with severe pain, was brought to the hospital and admitted with the diagnosis with left deep vein thrombosis, which is left leg DVT. The medication that the patient is getting is ART, enalapril 10 milligram PO, OD, and Actrafane 20 in the morning and 10 international units in the afternoon, during night, and Adalat 20 milligram OD PO, Gloxacillin 1 gram QID PO, Glexane 80 milligram subcut, amitriptyline 25 milligram PO OD, warfarin 5 milligram PO OD, Dalcolax 10 milligram PO TDX. And then the social history of the patient. The patient is a retired, as you can see the age. She was a cook in a hotel a long time ago. Educational status, it's primary. Socio-economical class is middle class. Marital status, she's married, not an alcoholic or a smoker. Relevant health condition in the close family. Her sister is also diabetic on treatment. On advanced directives, there are no prescribed as a directive, no DNR or anything. There is no living will. There's just nothing the patient has on this condition, on her condition. The healthcare proxy is her husband, who is still alive. Mental capacity was assessed and patient capable of making all necessary decisions, awake, conscious, GCS 15/15. Review of system. The vital signs, temperature is 36.5, BP is 131/68, pulse it's 87 beats per minute, RR it's 24, RBS on that day in the morning it was 6.3 millimole per liter. The pain score, hello? The pain score was 3/10. Sorry for the misprint there. It's 3/10 on the presentation. And then the ECOG functionality score, the patient is confined to bed, assisted with self-care, mainly due to the current condition, because she's afraid to just move her limbs or anything because she's afraid of the pain. But before the DVT, the patient was fully functional, able to do everything self-care wise. And then the ranking of the pain of the symptoms, there is no dyspnea, anxiety is 2, agitation, there is no agitation, no depression. Drowsiness, she is loudly drowsy after the commencement of the morphine, which is 1. Nausea and vomiting, none reported. Anorexia, none. Constipation, none. And dry mouth, it's 1. But mainly to the fact that she's mostly sleeping. I think it's just that cause. Then poor mobility, it's 4. Then focused investigation. I just picked the matters of concern from, because she was done a full FBC. So I just picked those that were of concern, but she did all the other tests. There is a urea of 26.9 millimole per liter, which is high, and then creatinine, which is 221 millimole per liter, which is also high, and it's a ESR, which is 150 millimole per liter, which is also high. And then further plan, we discussed care of patient with daughter and also the education on the administration of prescribed medication. Also advised on notifying nurse or doctor on any abnormality noted, to also elevate the left leg, which is the swollen left leg. On symptoms control, we are planning position change to maintain skin integrity and prevent pressure, bed, bath, and care of pressure areas, physio to help in the circulation and healing, and also to not taking of the medication as prescribed, because right now she really needs the medication. I thank you.
Thank you very much for the lovely case presentation. I think it was well clear, colleagues. I will just, in the interest of time, I would just like to ask if ever you have a question or comment or discussion, please feel free to say whatever you want to say by simply raising your hand. And also you can write on the chat box on how best can we help the patient on our case for today. This platform, remember, is for everyone. Actually, we need to help one another as healthcare workers. So it's good that we discuss and communicate on the issues that may help one another improve or to handle our cases in a better way. We are really grateful, Babane, for the case presentation that you have given us today. And we hope that there's much more that we can share as healthcare workers to help one another. Is there anyone with a question or a comment? Colleagues, feel free, this is your platform. This is our platform to communicate. Is there anyone from my side as well? how can we best help our clients be?
I have a question for Temalangeni. I saw that the patient is on morphine. I don't know whether it's the MST or the liquid one, BD, which is 5 milligram BD. And then I saw that the patient has experienced abdominal crampings since 10 days. So I just wanted to know that if the cramping has begun after the prescription of morphine, or was just another thing on assessment, what could be the possible cause of the complaint of the cramps?
Thank you, Mr. Mahlang, for the question. I think it was clear to you, Temalangeni, and everyone, whether the cramps began after the administering of morphine, or was it something that was there before? I can also see a hand from, may you please unmute yourself and.
Hello everyone. Thank you, Babani, for the case. I was actually on the pain management. I actually saw that the patient is on morphine, and we would actually love to know, was it actually a stepwise, or we just started with morphine? Because I'm seeing morphine now, and it's now a 12-hourly dose. I'm actually just wondering if the patient really, if we really need to go as far as morphine, where did we start as far as the pain management is concerned for this particular patient? I saw amitriptyline as well. I would like to assume that it is used as an adjuvant, because it just said amitriptyline only. I would assume it's maybe an octet dose for amitriptyline, but as an adjuvant. So where did we start with the pain management? Thank you.
Thank you very much for your question. I think it was clear on our side as well. I would like to give Temalangeni to respond to what questions. I thank you, Mahlang. And the other question from.
Thank you so much for the questions. For the morphine, it's liquid morphine, which she was given 5 milligram for hourly initially. It was a step up because we were consulted as a palliative. That's why I'm saying it's a follow-up patient. After the doctors have given diclofenac, and we also find that the patient was already on amitriptyline. That's when we got into the morphine 5 milligram. She was on diclofenac, Panadol, and they stopped the Panadol. Looking at the results that I've shown, is saying we are now having some problem with her system. So they stopped the Panadol, and the patient was on diclofenac with the amitriptyline, but still complaining on severe pain. The patient was not sleeping, was shouting all throughout the night. So that's when the morphine got in. So it's the morphine 5 milligram, which is liquid morphine. And then on the abdominal cramps, this was the presenting symptoms we got on the patient on the first visit after the consult of palliative on the morphine issue. We found out that the patient had severe abdominal cramping and pains. So the report we got after the commencement, that's why we went to the, as I've reported, there was a time that because the patient was now drowsy, was that the pain has subsided a little, but now the complaint was on the drowsiness, because the daughter was saying, I now don't have the communication with my mother, she's always asleep. Thus, the 5 milligram BD of the morphine. Thank you.
Thank you very much, Temalangeni, for your responses. I hope it was clear. Okay, yes. Also, if ever there is another question, please feel free to ask. I'll hand over to Mr. Mhlanga.
Thank you very much, Ngozi, for an informative presentation. I am worried about the morphine here, the drowsiness actually of the patient. And when I looked down here on current medication, I can see amitriptyline, which intensifies the drowsiness. So I was just asking about the indication of this amitriptyline regarding the patient's condition. So because the morphine itself causes drowsiness and together with the amitriptyline, so what was the indication of amitriptyline? Yeah, that's my question.
Thank you, Mr. Sabelo. Temalangeni, please respond to that question.
Thank you so much. Okay, the amitriptyline was prescribed prior to the morphine with the pain management. That was the doctor's prescription prior to the morphine prescription, while they were still trying to control the pain. So the morphine comes later, which that's why we had to step down on the morphine because the drowsiness started after the morphine. So the amitriptyline was already there as a prescribed. But yes, I get your concern on the fact that also amitriptyline will cause drowsiness. And I think there has to be some better care or maybe step down on the amitriptyline or even stop it and give the morphine.
Thank you very much, Mr. Malangeni, for your response once again. I think it was clear on our side as well, because we're trying to find a way to best help our patients. At this point in time, I think we have.
Nana said a question or a comment. He said the abnormal cramps was a question that did they start before, after the initiation of morphine, and if yes, how were the bowel movements for the patient? I think the Malangeni has cleared up that the abdominal cramps were presented before the initiation of morphine. So I think that was clear.
Okay, thank you so much, Mr. Mahla, for that. Are there any further questions or comments, colleagues? We're about to close our session for today.
My concern is the issue of mobility and the opioid and the age. The patient is ECHO-4, which means it's totally dependent on other people for 8 years, the activity of ABE. And that I don't see laxative prescribed for the elderly person who's taking the opioid now. I don't know if Babane have ever prescribed laxative. If they prescribe laxative, what laxative they provided for this one? Because looking at the functionality status of the patient, ECHO-4, there is a possibility that we may just be a constipation leading to fecal infection, sending the patient to theater, but looking at the age, then being impossible also. because of the calibration. I don't know any preventative measure for the issues of bowel movements when taking the opioids that have been put in place, looking at the age and the medication being taken and the facilities there. That's this one. What is being used now to prevent constipation for this patient? Thank you.
Thank you, Mr. Matang. I'll let Emalangen to respond to that.
Thank you so much. I think I mentioned when I was presenting that the patient is on Dalcolax 10 milligram PO TDS. So that is taken care of.
Okay, noted. Thank you so much. And thank you so much. Is there anyone who would like to add something before we proceed? It's towards the end of our session for today. We're sorry that it has taken long, but it's a learning platform. We all want to learn. If it was my will, I would like that we can have the session every day, but unfortunately we can't because we're all committed where we are committed. Otherwise, I think this platform can really help us in many aspects. I would like to hand over to Mr. Matang for our next session on updates, whether there are any.
Thank you so much for attending to this session. There are a few things I will recommend and add to what a wonderful case from Babane. Thank you so much, Babane government, for managing such a patient. Elderly patient is not an easy thing. But what I want to say is that we understand that elderly people, when they come to mental health and other issues, they are prone to depression and they are prone to anxiety and other effects. So we need to be very cautious. I think one of the first assessments that we need to do is to go beyond the symptoms presented or the illness, the physiological part of the patient. We have to go into the issues of psychological. How has the disease psychologically affected this woman? This man, the woman is married 71 years old with a husband. The husband possibility, looking at the culture, you will find that it's an older person than the woman. So we have to look around how psychologically has this condition affected the husband and the patient. And also this patient family, looking at the family stage of development, we can say now is either an emptiness or an extended family. So we need to find out the issues of social support for this family. Getting to know that this one is already dependent patient. It means that we need to get to know closer the caregiver, who is giving care to the patient, and how has the caregiving role affected that caregiver. I think that assessment needs to be also be carried on, so that as a facility may know, sometimes the patient will come to the hospital for refusal follow-ups, then we understand what is happening. Also to do the social assessment, understanding who is completely supporting this retiree, and who is there to ensure they are coping well with the family setup, the support, who is continuing to do the things for them, and how are they also coping with the situation. Another issue is the issue of spirituality. You know, in this country, there's too much spiritual. We need to understand the spirituality that are rotating around. I don't know how long this patient has been into the unit and how long we have been able to be with the patient. Looking at the disease trajectory, now the patient is bedridden, you will find that the patient has been able to ambulate and do things. So what is the spirituality of the patient? Where does the patient draw strength and love, hope from? And then does the patient have a spiritual community? What is their spiritual community? You know, we need to understand those things because they determine how the patient copes with the pain. You will find that the patient is complaining of pain, but the pain is aggravated by the spiritual, social, and psychological issues that we may have missed while we were doing the assessment, looking at what was presented, which may not be treated even by morphine. So I would recommend let's look closer to the spirituality part of the patient, let's look closer to the psychological part of the patient, let's look closer to the social part of the patient. Then again, let's come closer to the issues of advanced care planning. You know, elderly people will find that this one is a retiree, but he has been working, he has got money. There are things they like, there are things they don't like. Today we're looking at court status discussion. And the patient who's at ECHO-4, like this one, we need to consider issues of court status discussion. For example, this patient has diabetes mellitus, has hypertension. So in these conditions, you will find that sometimes they will be brought into the ICU or they will be brought into the emergency room, requires some certain therapies. We know at ECHO-4, sometimes the palliative phase of a terminal or deteriorating phase, these patients, they will begin to refuse to eat, or else the issue of feeding will come to a stop. Then you will find that the cultural issues or spiritual part of the family will shoot up. They will come and compel the clinic to do feeding. So it's very appropriate that at this time, you consider issues of the court status discussion, should in case you are unable to feed yourself or you are unable even to speak and your family wants to feed you, yet you are not hungry because of the disease level you are in. Should we continue with that? You know, so those discussions that the family will say, should I get sick and at the end of my life, I don't want to be admitted. Even the issues of the preferred place of death. If the patient wants to die, where would she want? Let's not start to discuss those issues with such patients when they are now unable to talk, unable to say a thing. But let's start while they are still able to speak, able to do other things. And now at this stage, we need to look around those issues to deal with the psychological pain. And we don't want this cool who wants to have life that is gone to be suffering, maybe because the children have detected things that her lover have told him that, that what he wants and what he don't want. So I will encourage us to look around those issues and address them at this point in time. Babane government may not have all the resources to follow up to do that. So we continue to encourage that you link the patient to the relevant stakeholders, their home base, their pastors, you know, to know what the change or the spiritual community of that patient a role to play at this point in time. In also relieving the caregiving. We don't want our caregivers to have burnout because really the statistics are showing that one or the other in this country, most of us will have the position to take care of people with life-limiting conditions. So we don't want them to have a burnout or else have a bad image of what is happening, but they want them to feel supported. Otherwise, thank you so much, Babane government. It was a wonderful case. We are happy that now the patient doesn't have physiological pain, but we still need to do further assessment of the issues of the social part, spiritual part, and then psychological part of the patient and the condition itself. Does the patient understand that now might not be a treatment to go back from these conditions? I saw that these conditions, they've been coming in and one by one. So we don't know what else is coming, looking at the age of the patient. So we need to prepare for end of life care. So we need to start now, finish the issues of court status. Today we'll be discussing how we can discuss the court status issue so that the patient can decide today. So that we can have a good decision making when it comes of the images issues. So we cannot run or find ourselves try and error on a patient, yet doing what the patient wouldn't appreciate at that point in time. That will be my parting shot and a support statement to Babane and say thank you so much. That's a great way to just continue to take care of our patient. One day they will pay us in prayer, if not the Almighty God doing it for us. So in our next session, we are about to complete the series of communication. Then we will embark on pain management and assessment series. So we are treating different series. Last session, we were treating ethical issues series. Then we moved to communication and palliative care series. So we are about to wrap it up. So as we know that the disease trajectory ends with end of life and death. So in our next session, we will be looking at how to communicate at the end of life or during the transition of death. How do we communicate? We know that In palliative care, we say we provide comfort until the last breath, even until the patient is no more. So we'll be looking at now. We have been able to communicate during the breaking news. We have been able to communicate during advanced care planning. We have been able to communicate during goals of care. Today we're sitting how to plan for the West. So we're looking at the court status discussion, how we can do it. So in our next session, we'll be looking on how then do we communicate during the transition to death. Now our patient is dying in our health. What's the communication that we need to provide for our patient? So our next session will be on the 24th of August. The same time, 1300 hours, we will be having that session. And we are encouraging each and every one of us, if you have enough time, go to our YouTube, ECHO-Eswatini Hospice at Home, and then you will have access to other resource materials that we've had before. Also, during our pre-session, we will share with you follow-up emails, and then we also share the link for registration. The registration link, we encourage you to share with other colleagues, because tomorrow it's me or it's my mother, it's my relative that will be a palliative care patient. So we want all our healthcare workers to be empowered and understand what to do in terms of this situation that we face. So thank you so much to attend today's session, and we will see you on the 24th of August, when we will be discussing now how to communicate during the transition to death. And then after that one, we will move towards the very interesting one again, which will be pain assessment and management. Thank you so much, everyone. May God bless you and bless our Indian team too. Thank you, Alina, I see you. Everyone, thank you.
Thank you, colleagues. Thank you so much for attending our today's session. And may I encourage everyone to encourage other healthcare workers to join us, because this platform is for us all to help one another to improve our care. Thank you so much. May God bless everyone. Thank you. Bye-bye.
Bye.
Bye bye.
Bye.